Okay. Good afternoon, friends and colleagues. Today, myself, Dr. Darpan Thakre, consultant neurosurgeon with 15 years practice in Bombay and attached at Raheja, a Fortis Associate Hospital. We'll be talking about prevention and management of head injury. It is a very common topic, and we come across head injuries in our routine day to day life. It might be at home, you might get hurt, you might fall in the bathroom. If you're outside, maybe at work, when you're driving four wheeler, two wheeler. So during one's lifetime, everyone has had some sort of head injury. It might be a minor, trivial head injury or a major injury. So, in short, I'll be trying to explain and make you all understand that what precautions you should be taking to prevent that, how you should approach when you have a minor head injury, how you can approach when you have a major head injury, or what steps should be taken, which most of our colleagues or local physicians, when we go to them, are unable to guide us. We are confused because sometimes the patient might say that he's having giddiness or he's having dizziness, or he might have lost consciousness for some minutes or few seconds, or there might be an event wherein he must have thrown a seizure, or there might be blood coming out from the nose or ear. So there are different ways the patient can present. If the patient is a child, the parents are panicky. If the patient is an elderly, he is unable to explain. Again, the kids, they become paranoid. They want to understand what exactly is happening to their kid or their parent. So, if you can't explain it simply, you don't understand it well enough. It is wisely said by Albert Einstein. So I'll be going through few aspects of head injury, and it has become kind of a silent epidemic. In India, we have almost 4 lakh cases every year, around 75,000 deaths happening per year. With the speed of vehicles going up, with the infrastructure coming up in the developing countries, we see various sorts of head injuries coming into picture. So it has become an epidemic, as I said. So we should be careful when we are out, when we are at our work, and you should be always wearing a helmet. If you are on a two wheeler, you should not be talking on the mobile. You should be using a seat belt. The vehicles should be daily or timely serviced, checked upon the air pressures, because the expressways, the speed limits have gone up. So lot of factors are involved. So I'll be putting stress on the clinical aspects of head injury and how I, as a neurosurgeon, and my team of intensivists, anesthetists, we take care of the patient depending upon the conscious level of the patient when the patient reaches the ER or the casualty. So the commonest cause, as I said, is motor vehicular accident, which is almost around 60 to 70%. Then fall from height or their own height is the second most common cause. Nowadays, we come across firearm injuries, which have become very rampant in the Western countries, as well in most of our interiors and the northern border territories. So, wherein you see a lot of gunshot injuries, assaults, It might be with stakes, with fish. So depending upon what type of injury the patient will present and the line of treatment will be charted. So we are seeing changing patterns of the traumatic brain injury. As I said, like with the motor vehicles now having a lot of updated systems, a lot of airbags coming into the system, which have become more protective. The quality of the vehicles have gone up, but still, in spite of having the best ammunition with us, we do come across a lot of road traffic accidents. So head trauma comes in various forms, various bewildering variety and types. It has its own special management consideration and prognostic implications. So the clinical examination and CT scanning are the primary ways to differentiate between the various types of head injuries. So whenever a patient goes to a hospital, the hospital should have a CT machine at least in-house so that we don't waste time, because the more you waste time, the more the brain is going to get traumatized because of the primary injury or the secondary injury, that is the hypoxic injury, because we don't know what is the mode of accident, because most of the time the accidents happen if at night or if no one is around. We really don't know how the patient has fallen from his bike or hit the vehicle. Only now with the CCTVs coming up, we come to know that yes, this was the mode of accident and this is how the car had gone and hit. So in spite of the airbags opening up, still the patient lands up with a lot of counter coup concussions, whiplash injuries, and injuries to the chest, abdomen, the long bones. So all these things need to be kept in mind. So if I have to characterize the traumatic brain injury, you have to divide it into mild, moderate, and severe, depending upon the Glasgow Coma Scale. This is nothing but a chart wherein you assess the eye opening of the patient, the motor response of the patient, and the verbal response of the patient. In the eye opening, whether the patient is spontaneously eye opening or is opening eyes to pain stimulus or is not at all opening the eyes. Motor response, it has some patterns which here it will be difficult for me to explain, but yes, if the patient is comatose, you don't see any response. And if the patient is in a vegetative state, the response of the eyes, the posturing of the limbs, that becomes the diagnostic clinch. So if the patient is having a mild head injury, the score, a normal score of 15, becomes somewhere between 13 to 15. In moderate, the score becomes 9 to 12. And in severe, it is from 3 to 8. So in mild, what you see normally the patient is lethargic, is disoriented. In moderate, you see besides the lethargic attitude, he's obtended, he follows commands. Sometimes he's arousable and he's confused. He's not able to tell, like, what was the sequence of events. They have, most of the cases have retrograde amnesia or antegrade amnesia. That again indicates the severity of the head injury. And in severe patients, they are deeply comatose. There is no eye opening or verbalization. They do not follow any commands. And the motor examination, as I said, it ranges from localizing to posturing of the limbs. So this Glasgow Coma Scale is a very important scale, a basic scale which all the primary physicians, the general practitioners, the neurophysicians, they need to have in their clinic, and they should be aware, like if the parent or the patient is showing this kind of symptoms, we should be clinically able to evaluate those things and try to put the patient into a grade of mild, moderate, severe. And then depending on that, we should push the patient immediately for an admission or a CT or an MRI. So we need to press the panic button if the patient is bad. So depending again, on what type of injury, whether it was a blunt or penetrating injury, a closed injury or an open injury, where the skull is, with the CLW, the skull bone is shattered, fractured, or whether everything is intact from outside, but then on the scan you see a focal contusion or a hemorrhage or a diffuse axonal kind of a pattern, and whether extensive hemorrhage is associated with that. These all we come to know either clinically examination, and later on after the CT scan is done, you see the internal findings. So as I said, like sometimes you don't find any radiological diagnosis. The X-rays are normal, the CT is normal, but yes, still the patient is not conscious or patient is obtunded. So then, depending on what the cause is, after the CT is done, we try to see whether it is an epidural or an extradural hematoma, a subdural hematoma, cerebral contusion or hemorrhage, subarachnoid hemorrhage, or a diffuse axonal injury. Here we need to understand the pathophysiology of the head injury. Like there is something called as primary brain injury, which happens because of the direct insult, direct damage, trauma, like contusion, sharing tissue, and the hemorrhage. And there is something called as secondary injury, where the tissue damage which occurs minutes to hours after the primary injury. This is if the timely intervention is not done or if the damage is extensive. The tissue lands up with ischemia. That is, the blood flow to that tissue is hampered. And by that, the brain swells up, the intracranial pressure goes up, patient might land up with hypotension, BP might go down, and might have bradycardia and arrest. Then various metabolic toxins are released, and they might be excitotoxic transmitters, oxygen free radicals, there might be calcium derangement. So all these factors need to be considered when you evaluate the patient clinically as well as with the images. So treatment options, the first thing is prevention. In prevention, as I said, we should be quite vigilant when we are on the road driving. If the person is a worker, is with a lot of construction work or the metro work going on, they should be taking care of their helmets, their protection gear. You should not be talking on the mobile. You should be checking the brake pads, the clutch pads of your vehicles. So timely servicing of the vehicle is important. So now with the speed coming up with the younger generation, we see a lot of news coming up in the newspaper that they are doing a lot of stunts at night, midnight, without helmets, and they're landing up with severe head injuries or maybe even losing life. So therein, the parents and the family, they are in, they become very sad and they are deeply disturbed because of a loss in the family. So all these things are very important when we consider such things. So head injury has to be, given quite importance, and along with that, definitely spine injuries which are associated with head injuries should not be forgotten. So you should have first responders who will help the patient, pick up the patient from there, try to get an ambulance, and reduce the duration from the site of injury to the hospital or the ER. There should be an EMS system or a ER resuscitation system or a team available in the casualty of the hospital, which we have at SL Raheja Fortis Associate Hospital. So our team is completely primed up with all these facilities with an in-house CT, MRI, and we were able to, in the recent time, manage some high-end road traffic accidents, and we could save the life of the patient and send them home. Then you should be doing definitive diagnostic test, definitive treatment if required. It might be surgery, ICU care, and neuro rehab, which is the most important part. So in the pre-hospital, when the patient after the accident has been brought to the casualty, what all is done in the casualty? So we check the airway, breathing, and circulation. We see the blood pressure. If the patient is in hypotension because of the blood loss or fluid dynamic changes, they have to be resuscitated and the shock has to be corrected. Then In the Western countries and in some parts, we do have a air ambulance facility where the patient can be picked up and brought to the casualty. And definitely, when the patient comes, he should be log rolled or strapped to the stretcher in a proper way with the Philadelphia collar, anticipating that there might be an evidence of spine fracture. You have taken care of the head, but you're not taken care of the spine. So with an undislocated fracture, the spine fracture, if it dislocates, patient can land up with quadriplegia. So it's the most important thing. So in short, like rapid neurological assessment, the GCS score, the cranial nerve examinations, the pupil size, gives us a clue whether the brain is herniating, whether the intracranial pressure is increasing. You have to keep on repeating these examinations every 1 hourly and see if at all the patient is not requiring surgery in the first 30 minutes or 1 hour. There is high chance that the patient might deteriorate after 48 hours or 72 hours. And therein you have to jump in and operate the patient. So signs of brain herniation are correlated with deterioration in the conscious level, shooting up of the BP and the heart rate going down. You have to immediately intubate, hyperventilate the patient, deeply sedate, maybe barbiturate coma, and elevate the head, administer anti-edema drugs like mannitol, Lasix, and simultaneously you need to check for polytrauma, that is chest injuries, abdominal injuries, any retroperitoneal hematoma where the patient is losing blood even after giving the corrections of blood transfusions. Then long bone fractures, femur, being the most notorious, or pelvic fractures where the patient has urethral ruptures and hematuриas. So as a whole, when a patient comes, has to be examined from top to down, and depending upon the clinical findings, you have to rush in for the investigation. It's a multi or a team effort, and a multidisciplinary approach has to be considered. And at any given time, 24 into 7, the team has to be vigilant and be prepared to anticipate and manage such patients. So, what are the treatment strategies basically? So, medical line of treatment, as I said, cerebral perfusion pressure, the brain perfusion of the blood vessels have to be monitored by correcting the shock and hypoxia. You have to reduce the intracranial pressure as early as possible, either by surgery or putting a extraventricular drainage catheter if there is, ventriculomegaly because of the blood which is spilled. Then general medical care comes later on once the patient is stabilized in out of risk. You take care of the nutrition, the treatment of the infection with the appropriate antibiotics, and there are various molecules which have been said to take care of the secondary injuries from the metabolite damage. So role of piracetam and strosate, prophylactic anti-epileptic medications with iptoin and levipil, they have been shown, there are some studies which have been shown that they have some protective effect. So as a neurosurgeon, if all these modalities of treatment are not working and there is, as I said, a classical extradural hematoma or an acute subdural hematoma, which is compressing the brain, pushing it towards the opposite side by say more than a centimeter, that is 10 millimeters, with herniation, it might be uncal herniation to begin with. Immediately, as a neurosurgeon, I need to take the patient in the OR after explaining the prognosis to the relatives that there is high chance of morbidity and mortality which is involved. So whenever you have these kind of acute hematomas with herniation, the chances of survival are somewhere between 20 to 40%. And then once the bone flap is removed, the clot is removed, the patient goes on ventilator with sedation. We have to wait for the brain to respond to this medical line of treatment wherein this metabolic damages need to be repaired, and therein we can see the improvement in the general condition of the patient or the Glasgow coma scale. So you need to monitor the intracranial pressure, the cerebral perfusion pressure. You have to maintain the pressure levels above 70, the intracranial pressure less than 20, with mannitol, sedation, hyperventilation, CSF drainage, and you have to repeat the CT scan as and when required, depending upon the clinical parameters. So We need to know some terms which are commonly used by the lay people as well, something called as concussion. So many people, they are aware of this term ki, sir, we had concussion, and maybe that's why I'm not able to balance myself, or I'm feeling slightly dizzy, or having tinnitus in my ears, I'm not able to focus, and mild irritative kind of headache. So these patients usually have a brief loss of consciousness with the normal examination findings, and the CT scan is usually normal. So they might be little lethargic or confused, but we need to observe these patients. You need to advise them admission at least for 48 hours. I usually prefer to keep them under observation and repeat a scan after 48 hours and see if everything is okay. Sometimes you see late onset swelling or edema coming, and wherein the patient can deteriorate further. The second term which you should be knowing is called as lucid interval. Lucid interval is classically seen in cases of extradural hematoma, wherein the hematoma, it's in a small size to begin with, where the patient is conscious oriented, and then suddenly he loses his consciousness, and then suddenly the pupil dilates, and you see that the patient who was talking and quite moving all around, and suddenly is gone down with the conscious level. So therein you should suspect that this is something which needs to be urgently taken care with the help of surgery. The hematoma needs to be evacuated. Then there comes this fractures. So fractures, as I said, they can be hairline fractures which need to be observed. But if a hairline fracture is going in the orbit or towards the ear or towards the nasal bone, you might have CSF leaks, you can have rhinorrhea, you can have otorrhea, and depending on that, we do the scans, CT cystonogram, to see how big or small is the defect, whether it is going to close spontaneously. There are various tests to confirm uh, whether it is CSF or something else. So beta 2 transferrin and the glucose levels in the fluid are compared, and therein we can come to know that this is nothing but the CSF. So depending how big the defect is, the patient might need surgery to close the defect. It might be through the nose or it might be through the ear. Now, if the depressed fracture, both the tables are depressed quite significant, more than a centimeter inside, and the brain is getting pressed, they need surgery. You need to elevate the fracture and do the repair. You have to see whether there is a comminuted fracture wherein a lot of infection, sand particles, dust particles, or foreign bodies which are sitting there, they need to be cleaned. Therein, you can't go in for a primary repair by putting a mesh or screw. You need to wait for a few weeks and then maybe take the patient up again for a mesh repair. Then there are some external signs which tell something called as battle sign or raccoon sign, which is discoloration around the eyes or behind the ear, which tells us that there is a fracture which is there below, and it can have a clinical significance if the patient is having ear bleed or nasal bleed. So all these fractures, they have to be taken care, except for the hairline fractures, which they either remain the same or they heal with time, depending on the age of the patient. If the patient is young or adult, then you have something called as cerebral contusion and hematoma. So whether it is a focal contusion hematoma, depending on whether it is frontal, parietal, occipital, or temporal, which are the main four areas of the brain, the presentation of the patient will be, and the size of the contusion will decide again the GCS of the patient. So if they are quite big, causing a midline shift, so we need to operate such patients, give some space for the brain to expand and the edema to be accommodated. These usually patients have a slightly higher mortality rate as compared to the extradural hematomas. Then comes your patients who are having diffuse axonal injuries. Diffuse axonal injuries are nothing but shattered neurons. They are deprived of oxygen and they are twisted, they are shattered, and thereby the patient is in a vegetative state or a comatose state. So in these patients, usually the prognosis is bad, the mortality rate is very high, they have deep comorbid status, and the prognosis usually is very, very guarded when we talk to the relatives. So with the impact, whether it's a coup injury or a counter coup injury or a diffuse axonal injury, the prognosis and the outcome has to be explained to the relatives. You have recently, now we come across a lot of gunshot wounds with an entry and exit. So it is a combination of everything. It can present as a subdural or a diffuse axonal or a shattered brain. And again, depending on what site, whether the patient is salvageable or the brain tissue is salvageable, the patient is taken care accordingly. Then you have traumatic subarachnoid hemorrhages, which can present as aneurysmal or an AVM bleeds. So we do have aneurysms post-traumatic. A DSA or digital subtraction angiography has to be done in such cases. So they can be either coiled or they can be clipped by open surgery. So in short, we need to understand that the head injury prevention and management is very important in our day-to-day activity, and you can get patients in elderly, they may present as a stroke wherein repeated trivial falls, they'll come up with a chronic subdural hematoma, but to the physician they'll present as weakness of the hand and leg. If it is a dominant side, they might be aphasic with memory loss, and when we do a scan thinking it to be a stroke, we see that they are having a collection there, which we usually manage by putting burrows and evacuate the hematoma, and the brain jumps out, and usually they do good, unless there is an acute bleed associated with it. So elderly people are very prone for this pattern of presentation, and so the take-home message here will be for everyone that you have to be careful, you have to be vigilant, you have to take care that you follow the discipline, the rules set by the road traffic controllers. You have to follow the road signs, you have to follow the markings on the road, where you can overtake, where you should not overtake. Seat belt is mandatory, no mobiles. You should be not driving when you're feeling sleepy. Then most of these bus accidents you see when early morning, 5 o'clock, 6 o'clock, the driver is conked and the bus is landed in the valley. So all these things need to be considered. So even though like the speed limits have come on most of our express highways, people have found out ways how to fool them, and it's very sad actually. Two-wheelers with the newer bikes, the super bikes coming with speed crossing 300, 400 kilometers or miles per hour, with no helmets and stunts on one wheel. All these things need to be stopped. They have to be given utter importance, because your family is going to miss you, and you will be kind of causing a lot of grave injury to their heart, and they'll be I mean, there are no words to say. Emotionally, they'll be very depressed to lose such a important member in the family. So head injury is a very important topic. So I think I have covered most of the variants and presentations and the management, how it has to be done. So thank you very much for the kind attention, and stay safe, take care, and have a good day ahead. Thank you very much.